Okay, that was your buzzer.
Okay, okay.
You can start.
Yeah. Hello, I am Dr. Deepak,
Hi.
hi, one of the doctor in antenatal clinic today. Can I confirm your name and age, please?
Hi, I'm Mary. I'm 25.
How can I address you, please?
You can call me Mary.
Okay, Mary. I am seeing that you are 25 years old, and this is your first pregnancy, and at present you are at 16 weeks of pregnancy. Is this correct?
Yes, that's right.
What about your pregnancy till now going on?
Oh, I did not know I was pregnant, doctor, actually.
Okay, okay, okay. Congratulations for your this pregnancy. Can I ask you a few questions?
Yes, you can.
Okay, okay. Uh, uh, how uh, how long are you trying for this pregnancy? Can you tell me?
No, I wasn't really trying for this pregnancy. It
Okay.
was an
Then
accident, possibly. Not quite sure
so
how this happened.
any medicine before this pregnancy?
No,
Okay. Any past significant medical history? Any other disease?
no,
Okay. Any past surgical history? Your
no,
tummy or down below?
no.
Okay. Uh, Mary, can you tell me uh, what is your weight to height ratio?
Oh, that's, I think, 24.
Okay, okay, good. And any drug allergy, any allergy to anything?
No,
Blood group?
it's B positive.
Okay, fine. Any reservation for blood transfusion is required, if required?
No.
If you don't get mine, can I ask you some personal questions?
Mm-hmm.
Are you smoker?
I used to smoke, but I've given up now for almost a year.
Very nice. Alcohol?
No.
Any
Occasionally I have.
recreational? Okay, okay. I will suggest if you can, please avoid alcohol during pregnancy. It can harm your baby. Any recreational
Mm-hmm.
drug?
I've been taking heroin, doctor.
Okay, then I think we should send you uh, any related groups to how to quit this recreational drug. Is it possible? Are you okay for that? If I send you any such group where
No,
this drug,
but why?
because it is very harmful to your upcoming baby. So if you please can quit this heroin, it will help your pregnancy to a healthy outcome.
Mm-hmm.
Okay. Any family history of any significant disease?
No.
Okay. Then how are you living? I mean, how are you are you doing any job at present?
At present, no, I'm not doing any job.
Okay. And support in your family?
I live by myself.
Okay. Okay. Now, uh, it is. I think this is your first visit after pregnancy.
Yes.
Okay. Any blood test done?
No.
Okay. Any other question you can ask me?
I just don't know how to go about things in pregnancy.
Okay, then we will discuss how can we continue your pregnancy to a healthy outcome. Can I
Hmm.
proceed?
Yes.
Okay. Now, as you are in 16 weeks of pregnancy, we will start your daily folic acid, that is 400 microgram. Then we will do all relevant blood tests like complete blood count, then
Hmm.
blood grouping, then uh, entity, then uh, RAs typing, hepatitis B screening, HIV, and uh, screening for syphilis, that is VDRL. Then we will plan for your ultrasound, how the baby is there. Is there any uh, uh, a single pregnancy, single baby or multiple baby? We should confirm. Then we will do your anatomy scan at 20 weeks, near about 20 weeks, where we should see all the uh, body parts of your baby. Is this okay or not? Then,
Hmm.
according to this, we will proceed further test report. As you are in low risk group because your BMI is within normal limits and no such major medical problems or surgical problems are there. It will be your visit will be in the midwife clinics. Okay,
Hmm. Yes.
and uh, there your plan will be according to the midwife clinic, and if there is any uh, problem detected, then the further imaging will be done. Okay, any other concerns you want to know?
Um, I want to know if heroin is going to affect my baby in any way.
Yeah, yeah. Heroin can affect your baby in many ways. Like it may cause to uh, 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 restriction of growth of your baby. Then it may lead to uh, hypertension and some
What
problems
tension?
of after the blood pressure. It may lead to high blood pressure. Then the problems of afterbirth.
Hmm.
So for this, you should undergo serial growth scans from 26 to 28 weeks of pregnancy. And then
Okay.
you will be started aspirin, one drug which prevents uh, high blood pressure and protein leakage in urine in pregnancy. We will start from this time.
Okay.
And if any abnormality in the growth of your baby detected from 26 to 28 weeks of pregnancy, then serial scans of growth and other Doppler studies will be done accordingly. And
Hmm.
everything is if everything is okay, then we will plan for your birth of the baby at around 40 weeks of pregnancy spontaneously.
Mm-hmm.
Any other concern?
No. Okay, doctor.
Okay. Thank you for the time.
Thank you. Well, okay, that was your timer. So what's your reflection? Can you see the screen well?
Yeah, I can see you.
You can see the full screen, isn't it?
No, only small screen of you.
Yeah, but okay,
Full
fine.
screen question is in the full screen and the small screens for attendance.
All right, fine. So, what is your reflection? What do you think happened?
Just I have tried. This is my first presentation.
All right, okay, fine. So, well, let's. It was a good attempt, okay. But what I would like to bring to your notice is that, see, when you attempt a station like this, when hardly anything is given in the station, something should strike you. What is striking from this particular station that is given to you? What did you uh, see is not usual?
Unbooked case. Booking visit is at late.
Yes,
Um,
it's a case of late booking. Yeah. So it is mentioned to you
yeah,
that she has booked at 16 weeks of pregnancy.
yeah,
So that should strike you, okay? The first thing, that is the only thing that is given to you, and it's given to you that she's 25-year-old. And if you did notice, I don't know, I may not be that good in acting, but the player didn't sound quite enthusiastic. She sounded low,
yeah,
right? She's like,
yeah,
okay,
yeah.
yeah, fine, okay. And she's an addict of heroin, right? That you found
Heroin.
out, which was good, okay. When you have such a girl, a 25-year-old girl who's come to you, like she's pregnant, she said she's living all by herself, and when you asked about her support, she said there's nobody, and so she's likely to be a high risk category. Social factors have to be looked into. You asked her about what does she do. She said, right now I'm not doing any job. Okay, that's because you asked her specifically if she does any job. Okay, you so you could have asked her further, like if she's a single mother, then how does she plan on supporting the baby, right? Supporting the child. Okay, financially, does she have adequate financial support? Okay, the first thing that you need to check on when you are considering a late booker, okay, and a single mother who's sounding low. Okay, so financial support. What does she do? So her sexual history. When she told you that this is her first visit and she did not know she's pregnant, you said congratulations. How do you know that this is a welcome pregnancy, right? You first need to ask her whether you want to continue the pregnancy. Is this a welcome pregnancy or not, right? Only when she
Yeah.
says that yes, I'm looking forward to having a baby, etc., then maybe you can say that okay, good, congratulations on the pregnancy. But otherwise, first thing you need to establish whether she wants to continue the pregnancy or not. If she's single, she's living alone, then you have to ask her about her partner, whether she or the partner supports her. Okay, whether she's in any high risk behavior, whether she was a commercial sex worker. If you had asked further, you had probed into it, then you would have got it. Okay, how would you know? This is a hidden agenda. These are the things that you should try to elicit from history, from the patient. Okay, so first you say when there is such a patient who is with you and not very forthcoming, she's okay, okay, fine. That is all that she's saying. I wouldn't have even asked you the question about heroin, but you were not anyway close to heroin, so that is why I gave you a clue, right? So when you have a patient like this, ask her if she's not forthcoming with history, tell her that whatever we discuss here is going to be confidential and it is between you and me, right? So all these things you need to say, and then you can say that don't mind me asking a few personal questions. Can you tell me, are you in a sexual relationship currently? Okay, so then she'll say yes, no, or the boyfriend, she's having a boyfriend, no boyfriend currently, whatever, she's going to tell you about it, right? So, um, then whether in the past she's had any other partners, then she would have probably told you that she's a commercial sex worker. She said, currently, I'm not doing any job. She's not very forthcoming with her history, right? So, all these factors are to be looked into. It is not that straightforward when you have such a patient. So social factors are very, very important. And when you have picked up that there is abuse of heroin, she could be having other problems, like she could be having domestic violence, she could be having sexual abuse. Okay. And then it doesn't stop at that. You have to ask a detailed history about heroin addiction. Okay, so how bad is it? How much? How does she procure the drug? How much of the drug does she take on? Does she take on a daily basis? Does she take IV drugs? Because IV drug abusers have a different set of complications that can occur. Okay, so you have to ask the specific questions which we will see. Okay, so initially when you started, you said you started fine. You said you can just ask the question straight away. Hi, I am so and so. I am one of the doctors here. How would you like to be addressed as? Okay, instead of asking, may I confirm your name and age? And then when she said Mary, how would you asked her how would you like to be called referred to, or something like that, because she said Mary, so obviously you're going to refer her as Mary, right? So that doesn't sound quite good. So you can just directly ask her. The opening statement can be, how would you like to be addressed as? Okay, then she will tell you, you can call me Mary. And what is your age? May I know your age? So she would say 25. So then you say that I believe this is your first pregnancy and you are 16 weeks through your pregnancy. Then you can tell her, then you can say, is it okay to ask a couple of questions, right? So basically, you need to ask her her current complaints. Is there any current problems that she's having? Can you see the slide? The next slide. Hello?
Yes, 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 yes.
Okay. So, does she have any current complaints? Okay. Has she visited in the past ever? Why has she visited late? So you could ask her. I can see that you booked at 16. You come for booking at 16 weeks. Any specific reason for booking at after 4 months of pregnancy? So she would tell you what are the problems. You can ask her questions like, does she have menstrual irregularities? When did she find out she's pregnant? Okay, she would just probably tell you that no, I always get irregular periods or something like that. So I didn't realize that I was pregnant. Okay, so was she using any contraception? Then was there any failure of contraception, etc.? All these questions are important. Okay, then particularly in a late booker, you have to ask initially all the social factors. So what does she do for a living? Rather than asking, are you doing any job currently? Ask, what do you do for a living? Then maybe she would have told you that she's a commercial sex worker. Okay, then are you well supported? It may be, you can even, before asking financial status, you can ask her financial support. Basically, you can ask that I'm concerned about the welfare of the child. So how do you plan on supporting the child financially? Okay, so that is how you can put the question about financial support. Is there any medical, don't say medical history, surgical history. How does the patient know what it means to have surgical history? What is surgical history? You're basically asking her, do you have any surgeries in the past? Okay, have a conversation. Don't act like you are answering an exam. Okay, you should try and have a conversation with the patient. So
Yes.
do you have you had any surgeries in the past? Are you having any medical diseases? Okay, any allergies, any previous pregnancies? Okay, then addictions, you are smoking, alcohol, drug abuse. Okay, when once you pick up drug abuse, you have to ask some few more questions about that. Okay, it doesn't end at that. Okay, the entire station, in fact, is about heroin abuse, right? She's 25, so has she got her first visit for first call for smear, cervical smear? Then sexual history, multiple partners. Have you had any other sexual partners in the past? Okay. Then have you been tested for sexually transmitted infections? Okay. Have you visited the gum clinic? All these questions are important. Again, you can signpost before asking these questions, right? You can say that, sorry, don't mind me asking a few more personal questions. Do you have you had any sexually transmitted infections in the past? Have you had any other sexual partners in the past? Okay, have you visited the gum clinic? So after that, it's a booking visit, remember. So you have to ask detailed history. Booking history is different from asking just relevant history to the situation. Here it is booking visit. So you have to ask booking history, which would include family history. Okay, it may not otherwise be relevant to the station, but since you don't have her booking history at all because she's come to you for the first time, family history of any significant diseases that could run in the family, and ethnicity, which ethnic group do you belong to? Important because that's a booking question. Okay, not required otherwise. Domestic violence is important. You can say, you can put the question as women in situation like yours may have history of being abused at home. Do you have any such history of violence at home? So she would say yes, no, whatever. And if that is there, then you also need to ask about history of being cut as a child. Okay, that is FGM history. So all these questions are booking questions. You don't ask them routinely, but definitely in booking. Okay. Then mental health is very important. She sounded upset or depressed basically. So you say, in the past few weeks, have you felt low or you think you need help or counselors? Very important, particularly in vulnerable population like these. You need to ask these specific questions. Okay, the occupation, financial status, support, sexual history, uh, partner history, whether she has basically whether currently she's with somebody, right? Then contraceptive failure, mental health, domestic violence, all these questions are very, very important. Okay. Then you say examine. When you say examine in the presence of chaperone with consent. Okay. Here you will need to check her BMI if she doesn't know that. Blood pressure. Per speculum examination may have to be done because you're worried about infections in her, isn't it? So, and also maybe general examination, you need not say it as such because if she's an IV drug abuser, then you have to specifically, particularly in a structured discussion for any sclerosed veins, etc., you would look for. Okay. Here you need not really say it specifically because it's a simulated patient task. Then investigations, we would do, you first say that since this is your booking, of course, you have to ask her whether this is a welcome pregnancy right in the beginning. And if she says yes, then you have to say that we would offer you certain booking investigations, which would be blood test as well as urine would be tested. That is done routinely in all patients. We would also offer you screening for sexually transmitted infections like HIV, syphilis, hepatitis B, and she's an IV drug abuser, which history was not asked. But if you had asked, I would have said that yes, I use the drug IV. Then anti-HCV is also important to be done. Screening for certain abnormalities in the baby, like Down syndrome example, would also be offered for you, and a dental checkup because she's heroin abuser. They have poor dental hygiene. Okay, and swabs for sexually transmitted infection, vaginal swabs. So these are the things that you would do for her. And as far as the history related to heroin abuse is concerned, you need to ask her how long has she been using heroin, what route of drug administration is she, does she want to cut down on heroin, because you want to know how motivated she is, isn't it? And how does she procure the drug, and whether she feels the the desperate need to procure the drug. So that shows withdrawal and will help you with the therapy. Whether this particular habit interferes with her day-to-day quality of life and her living. Okay, whether there is history of violence with the partner, which we have already covered, and has she increased the dose because there is tolerance to this drug can happen. So whether she's lately increased the dose of heroin, so you know that you're dealing with something very serious. Okay, if all these things are there, okay, that she has the desire to procure the drug, and it interferes with quality of life, she cannot cut down all these things. If they are there, you have to be more careful. So that is why it is important to ask these relevant questions. Okay, So this would be your history, examination, and investigations, which all of these points would come under the domain of information gathering. Okay, so remember that communication, empathy, sensitivity, avoiding medical jargon. Like you said, hypertension. I asked you what tension, what are you talking about? So be careful. Okay, information has to be given in chunks and not continuously. So you need to check understanding in between. So heroin is an important point that, or the one major factor that you have identified her, in addition to the fact that she's a commercial sex worker, which was the role in the role player script. So in effects on the mother, in this case, what you could say is basically she could have a preterm labor. And what we are really worried about is bloodborne infection. Amenorrhea or oligomenorrhea is just for your information. You don't have to tell her right now because she's already pregnant. So you say preterm labor, bloodborne infections, and clot formation, okay, and heart problems like endocarditis, etc., can happen because of the IV drug abuse. Okay, so this is that endocarditis, all the other infection risk is also increased, and clot formation. These are things that you have to remember. Okay, particularly because of IV abuse, not directly because of heroin, but IV abuse. Then there may be effects of this drug on the baby as well, right? So which you can include preterm delivery. Baby may grow smaller. There is a risk that the baby may be born with low birth weight. There is also a small risk. I don't mean to scare you, but I want you to be informed. There is a risk that the baby may even die in the womb, and if born even after birth, baby may have difficulty breathing. Baby may have symptoms of withdrawal that we refer to as neonatal abstinence syndrome. Okay, because the baby is exposed to the drug in utero. What happens after delivery is that there is withdrawal of the drug, which is why the baby may have certain symptoms. So that can affect, right? So that is what you need to tell her. Okay, that can even result in death of the baby after delivery, or long term problems with the development of the brain development of the baby, so cognitive problems. Okay, so what you need to remember here is that it does not increase risk of congenital abnormalities in the fetus. Okay, then in short, you have to talk about neonatal abstinence syndrome. You wouldn't have the time to do a detailed discussion. In case it comes as a structured discussion, then maybe they would ask you in detail. But for simulated patient task, you say that baby would have withdrawal symptoms after delivery, they may have difficulty breathing, they increase muscle tone, and sleep disturbances, tremors, irritability, and fits in the baby, vomiting, poor feeding, etc. Okay, you can just tell her a few things, and rest of the information which is here is you need not really mention, but may be important in a structured discussion. Then, what are the antenatal care point? Now, you said that since there is no risk factor or something like that, you said you can follow up with a midwife. No, maybe she can follow up with a midwife, but she will need definitely a team of doctors looking after her. Maybe a midwife can visit her at home, okay, but she would need a multidisciplinary team, maybe in a specialized clinic, because in alliance with drug and alcohol services, because she occasionally uses alcohol as well and she is vulnerable. So you need to have multiple specialties seeing her. Okay, she could be offered a visit to the dentist for dental hygiene because it is common in opioids. Okay, poor dental hygiene. Then screening for the growth of the baby, sexual health screening, which you have already said. These are the safety points, patient safety points that I'm mentioning here. Okay, there would be points here which would come under applied clinical knowledge as well as patient safety. The points which are very important, like sexual health screening, multidisciplinary team, these are the safety points. Okay, additional information like, for example, here dental hygiene, visit to a dentist, these would come under applied clinical knowledge. Then, if since she is IV drug abuse user, you have to also offer her, if required, that is, if indicated, maternal echo, because you are worried about endocarditis. Okay, so how you say that? You say that you would offer a scan for the heart to look for any evidence of infection in the heart. Okay, and also there is a possibility of clot formation, so you may be offered some blood thinners or other measures for the score here would be 1, so you can offer her blood thinners and other measures. Then urine should be also sent for testing. Okay, and for the drug levels, and in the pregnancy also, to see if she's maintaining, the substitution therapy or whatever she started on. You need to do frequently in the pregnancy as well, so urine toxicology has to be done. Okay, and at 32 weeks, just like in mental health stations or patients with mental health issues, we have a conference at 32 weeks with the patient, social services, etc., and the doctors, safeguarding people. So all that conference would be held at 32 weeks. Okay, so you say that at around 32 weeks, we, in order to look into the further plan of the management of the pregnancy, labor, and delivery, and after that, we would have a conference of specialties who would be looking after you. Okay, an anesthetic review also would be offered to you to discuss pain relief measures in labor. Why is this so important? Because she is opioid abuse. I mean, she's abusing an opioid, so they need higher level of analgesia, and opioids that we generally give in labor may not be sufficient for them. So that is the reason. Then yeah, so basically you have to tell them that there is a risk of perinatal mental health. So when you ask her a history like about mental health in the past few weeks, have you felt low or depressed, then she may say something to you, or she may just ignore it. Okay, so you say that we could also, there may be an increased chance of having mental health issues in pregnancy. You can tell her that. Okay, there may be an increased chance of having mental health issues like depression in pregnancy, which is why we could also involve the mental health services in your care. Okay. Other important safety point is rule out domestic violence, which you have done in information gathering. Social workers involvement, you would say in the multidisciplinary team. Also tell her that there is financial help available as well. Okay, so there is employment and support allowance and the work scheme which is available. Okay, so it is basically a rehabilitation for these drug addicts that can be done for her. So financial help, social workers, mental health services, the multidisciplinary conference at 32 weeks, anesthesia review, all these points are very important here. Okay, so then you talk about what can be done for her for the treatment purpose. So what you can do, you can say, you see, all these points here again may not be very important for you to say, you will not have the time. So in brief, you just tell her that we would be offering you, since you are addicted to heroin, we could offer you other lighter drugs like heroin, which are like methadone or buprenorphine. Okay, which would not have the same effect of as heroin, but it would have a lesser effect as compared with heroin, and it would help you to give up heroin. Okay, so these are the substitution therapies. So you tell her that these are drugs which do not have the same effect as heroin, but they are similar to heroin, and they are used as substitution because it would help you to give up the addiction of heroin. Okay, then also we could you take help of psychological intervention to help you give up heroin, because this is important for the health of the baby as well as your health. Okay, so other important points that may be important in uh, structured discussion for you would be that if a patient is stable on one substitution therapy, you need not just change it to the other. Now remember, in pregnancy, methadone is usually used because the evidence with buprenorphine is not much. So methadone is used. But if she's stable on buprenorphine, you continue the buprenorphine. Okay, you have to tell her that the substitution therapy may also cause the result in neonatal abstinence syndrome, because ultimately even these are heroines, I mean opioids. So they may also result in neonatal abstinence syndrome, but they are necessary for giving up the addiction for of heroin. sudden stoppage of heroin is not recommended because then you will get withdrawal symptoms. Okay, so you say that we would offer you medicines which could replace heroin, okay, like your methadone and buprenorphine. In addition, psychological intervention will also help, and we do not advise that you suddenly stop heroin. Baby may have effects of neonatal abstinence syndrome with the substitution therapy, but it would be less severe. Okay, and the levels may have to be changed in the latter half of the pregnancy for methadone. Okay, but again, these all these points you need not say. You just tell her about methadone and buprenorphine, maybe other drugs that can be used, which have a lighter effect or a lesser effect, but they would help to give up the addiction of heroin. And psychological intervention, even if you mention this much, would be fine. See, what is important in part 3 is that you mention the points that are important, and once you have marked the points in the answer key of the exam, the number of points that you have covered is more important. So I would suggest don't elaborate on one particular point, but you have to cover and touch upon multiple points. Like even if you say I would offer you substitution therapy, but you have not elaborated on it, it would be fine as long as you covered other points like support, counselors, anesthetist review, multidisciplinary team. But if the entire station you have just talked about of substitution therapy, then you would probably get a zero. And if you're not talked about all these other factors that you need to look into. So it is important for you to cover points. Okay. So as far as the delivery is concerned, if there are no complications in the pregnancy, she can have a midwife led delivery. But since and it is not necessary that a pediatrician is present at the time of the delivery because of the baby's symptoms, but maybe another midwife can be present. But again, you can say that in the station, in the exam, you can just tell her that you would be depending on the complications that arise. You may be offered either a midwife-led care in delivery, during delivery, or obstetric delivery in a hospital. Okay, cesarean section only for obstetric indications. Early IV line may have to be established because the veins are usually sclerosed. The methadone or buprenorphine that is used for substitution would be continued. You may need more or higher doses of analgesics, opioid analgesics. Okay, she may need higher doses. So that is what you need to tell her. And again, these points again mentioned here are not important in an SPT, but they are important for structured discussion. Okay, like for example, in opioid analgesics, when you offer, it is recommended that you wait for at least 2 to 8 hours before giving buprenorphine. Okay, like you continue buprenorphine and opioids, so you don't have to, should not be giving two opioids at the same time. Okay, that is what is the purpose. So this is the basic simple point that you can mention if it's a structured discussion, because the station can come as a structured discussion as well as simulated patient task. Okay, epidural is usually encouraged because it is safer. Continuous CTG for the baby because baby can have CTG abnormalities. Okay, and yeah, so these are the basic points. Postpartum care, your analgesic, your painkillers would be looked into. Would make sure that you have adequate painkiller, as you would require higher levels of painkillers. And that is all that you need to say. Again, these points in detail are for structured discussion. Baby would be monitored, okay, every 4 hours, first after 2 hours, and every four hours with a validated tool to monitor for the syndrome, okay. And baby would be kept in the hospital for 72 hours at least, and skin to skin contact would be encouraged, and feeding would be encouraged for the baby, okay. Usually most of the babies would do fine, but some babies may require admission to the unit. All right. So, and breastfeeding, you say that when if she continues using heroin, then breastfeeding may not be safe for her, for the baby. And methadone and buprenorphine, which are the substitution drugs that would be offered to you, are transmitted in the breast milk in low constant concentration, so they would not cause much harm to the baby. Okay. So if she's on substitution therapy, you can continue breastfeeding. But if she continues to take heroin, you have to tell her that you should stop breastfeeding. Okay, and one more point that you need to make you mention is contraceptives. And when you are saying contraceptives, condom, safe sex practices and use of condoms has to be encouraged. Okay, so that is what you need to mention to her. All right. So in brief, to summarize, sorry. Okay. So yeah, and this is another important point which you need to tell her, that even after she goes home, a community midwife, health visitor would come to you, would help you, would visit at home. Safeguarding risk assessment would be done. Opioid substitution therapy would be continued, and follow up would be arranged for you. We could also offer you a regular mental health screening as well, and information would be provided about safe sleeping and bed sharing, because they have the habit of sleeping in crowded environment, and then baby can have sudden infant death problems. Okay, so all these points are very important. So basically, in brief, you just tell her, once you finish your history, which is expected to you to we expect you to finish history in around 3 to 4 minutes. Once that is done, you tell her that,
Ma'am, no voice.
hello, hello, can you hear
Yes,
me?
ma'am. Yeah, yeah. Now we can hear you.
I think I got disconnected. All right, so I was just summarizing for you mm, the station. Basically, what you need to do after your history, you need to tell her that, I can see that you've been having using heroin. Okay, do not use the word abuse because she will not like it. You say you've been using the drug heroin, which can have certain harmful effects on you as well as your baby. As far as effects on you is concerned, you tell her that you can go in preterm labor and you can have infections because of the IV drug abuse and IV drug use, and infections of the heart, and increased chance of having clot formation. As far as the baby is concerned, there is a risk of growth problems, prematurity, and I'm sorry to say, I don't mean to scare you, but there is also a risk of death in the baby. After delivery, the baby can have sudden withdrawal of the drugs because it is exposed to the drugs in the womb. So can have symptoms of withdrawal, including fits, seizures, fits, tremors, restlessness in the baby, poor feeding, etc. And you tell her that, as far as the care is concerned, as such, you say that you would be offered a care in it by a team of doctors that would include specialists, even the drug and alcohol services as well would be involved. We would could offer you screening for the growth of the baby. Your dental appointment also would be offered to you for dental hygiene, sexual health screening, which you have already said in the information gathering. Your urine would be checked regularly for the drug levels, and a multidisciplinary conference would be held at 32 weeks so as to have a plan for you in the pregnancy, including the safeguarding services and social services. Anesthesia review would be held for you at 32 weeks, and then you talk about financial help that is available, and mental health screening, and mental health specialists may also would be involved in your care. Okay, we for in order to help you with giving up heroin, we would offer you substitution therapies like methadone and buprenorphine. Okay, so now this is a different set of information that you're giving. So before that, you need to ask, am I clear so far? Do you have any specific questions? Okay, then you go to the next part. So opioid substitution therapy. So we would give you methadone or buprenorphine. These are drugs which are similar to heroin, but they have a lesser effect, and they would help you in giving up the addiction. Psychological intervention will also help you, and we do not advise that you completely suddenly stop the heroin use. Okay, then and at the time of delivery, you would be offered delivery depending on the complications in the pregnancy. You can have a midwife-led delivery or a delivery in a hospital. Cesarean section only for obstetric indications. You would be offered an early placement of an IV line because of the possibility of sclerosed veins. And you say that methadone or buprenorphine, whatever is used for substitution, would be continued in labor. You would need higher levels of opioid analgesics, and we would make sure that that they are given you in a safe manner. And epidural would be encouraged. Your baby would be monitored using CTG. Okay, and after delivery, your baby again would be monitored for symptoms of withdrawal on a regular basis. They would be kept in the hospital for around 3 days. And then you say that we encourage that you feed the baby regularly, and skin to skin contact would be encouraged. If really, it may be so that the baby would require admission to the unit, to the special unit. Breastfeeding, as long as you are not taking heroin, is safe. Breastfeeding is safe on methadone as well as buprenorphine. And we would also offer you contraceptive advice. We encourage you to use condoms even if you use other contraceptives because of prevention of sexually transmitted infections. At discharge, what you're going to do, your discharge, you're going to tell her about, we would look into your social factors like living arrangement, and make appointments for you on a regular basis to continue the substitution therapy. Safeguarding risk assessment would be looked into, and there would be a visit from the midwife or a health visitor wherever you stay, and information about safe sleeping and bed sharing would be offered to you, and mental health screening would continue. All right. So after all this, you say, am I clear so far? To any specific questions? Okay. And remember to give her information to read. All right. Is that clear, everyone? Any specific questions?
Yes, ma'am.
All right. Okay. Good. Fine. So, we can take the questions in the end. Um, can we have another volunteer, please? We'll do one more station. Hello? Any volunteers? Or I'll pick up. Dr. Apurva?
Yes, ma'am.
Okay. Yeah, you can start.
Hello, I'm Dr. Apurva, one of the doctors in the clinic today. How would you like to be addressed?
You can call me Susan.
And how old old are you, Susan?
I'm 36.
Okay, Susan, what do you do?
I'm a homemaker.
Okay. So Susan, I went through the notes and have realized your concern. So we would be addressing it and making a plan how to move ahead. But before that, is it fine if I ask you some questions?
Yes, okay.
All right. So as I see that you are 16 weeks into the pregnancy, so are you right now having any complaints like pain or any discharge down below?
No, I'm not having any issues.
All right. And how has the pregnancy been so far?
Well, it's been smooth. This is my first
Hmm.
pregnancy, and we're really happy about it. So, I've not had any issues, except for the fact that I've undergone this procedure six
Hmm.
months ago, and they'd called me back for repeat screening after 6 months. So I've done that.
Hmm. Okay. So I'll be addressing it in a short while. Uh, so any the investigations done prior, like the booking investigations and the down screening, all have been normal as per your knowledge.
Yes, everything is done. It's normal.
All right. So it was a planned pregnancy.
Not really, but it is a welcome pregnancy.
All right. Congratulations on that. And what contraceptives were you using earlier?
We were using condoms.
Okay. Any specific medications are you receiving in the pregnancy?
I was taking folic acid and oh, that's it.
Okay. So about this investigation done, the treatment done 6 months ago, I would like to know a little bit more about it. So tell me more. What complaints were you having and all?
I was not really having any complaint as such, but sometimes after sex I had a little bit of bleeding, and
Okay.
and my smear, the screening that was done was showing some abnormalities, which is why they
Hmm.
did this colposcopy test, and they found that there is some abnormality in that biopsy, which is
Hmm.
why they called me in 6 months.
All right. And did you have any pregnancies in the past?
Oh no, this is my first pregnancy.
All right. In this pregnancy, have you been vaccinated for any against any infection?
No,
And any medical condition for which you are visiting GP?
no,
Any surgeries in the past?
no,
Allergies to food or drug?
no,
Don't mind me asking, little personal question about your lifestyle. Do you smoke?
no. I don't smoke.
Take alcohol?
No,
Any drugs for fun?
no.
All right. Are you aware of your weight to height ratio?
It's 24.
Hmm. And the blood group?
Be positive.
Any reservation to blood transfusion if you have made?
No.
And how do you feel your support at home? Do you feel well supported?
Yes, I live with my
Okay.
husband, so yeah.
Okay. All right. And any feeling of anxiety, irritability, or feeling low down, depressed in the past few months?
No, 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 I'm fine.
Okay. You may find little questions intrusive. I would like to ask you, uh,
Hmm.
did you have any episode of sexually shared infections in the past?
No.
Any change of any sexual partner earlier to your husband?
Oh, yes, I've been in fleeting relationships before I met my husband. So, yes, I had.
Okay, all right. So, were you using condoms at that period of time earlier before your marriage?
Not always. No, not
Okay,
always.
all right. So that's all I wanted to know, Susan. I would like to examine you in front of a chaperone now, and then I
Hmm.
would be we would be taking your vitals and examining your tummy in general, and about and feel to have the feel of the baby as well. Is that okay with you?
Okay.
All right. So, I have done your examination. Now let's talk about the procedure done last and now how we're going to follow you up. So, as you said
Yeah.
that 6 months ago, there was in the colposcopy, SYN3 was found, a high risk lesion was found, and that's why they did the uh, procedure leads. So, could you please tell me what do you know about, I mean, your understanding of the procedure? Can I please know about it?
Yeah, actually, I know that the biopsy was taken from the neck of the womb and it was visualized under magnification. I know that.
Hmm.
Will I need
Okay.
to undergo the same now?
Yeah, actually, I would be first informing the consultant as well, and then we would be making a plan together. Since 2 weeks back, you had a follow-up, and in that, the HR-HPV, the smear test, it was found positive for the high-risk virus. Are you aware of this
Oh,
report and the understanding behind it?
oh, no, not really, but it's still there. I know that it was there the last time as well, so it's still there, right?
Yeah, yeah, it is still there. And when the smear was done, it has been found that it is still high-grade lesions in the neck of the womb. So we would be
Oh,
planning a colposcopy, a camera view of the neck of the womb again, and then we would be
uh-huh.
seeing what exactly the lesions, I mean, what exactly it is the lesions are. And if we see any abnormality in the neck of the womb, we would be taking the sample again to see how much abnormal cells are
But
there, and then
doctor,
we would
I'm
be
pregnant, so would it be safe in pregnancy?
yes. So the colposcopy we would be doing the camera test to know the lesions in detail and to see the neck of the womb. And after that, since it has been found in the higher grade, and we would be taking the tissue sample. I would be consulting with my consultant as well about the same. But if at
Mm-hmm.
all some abnormal lesions are found and any treatment is planned, then we may defer it till you complete your pregnancy.
Okay, so a colposcopy was done, and the punch biopsy of the cervix revealed squamous cell carcinoma with invasion up to 4 millimeter.
Okay.
Now you can continue
Uh,
the station.
yeah.
Consider that she's
So,
come to you at another visit. Yeah.
okay, yeah. So Susan, now the camera test was done and the tissue sample was taken. So have you been told by anyone about what the report says?
No.
All right. So I would like to, the report comes with some explanation. So Susan, if you find anyone to sit with you while I explain you things, I can wait till someone from your family comes.
No, is everything all right, doctor? What is it?
Okay. Okay. So Susan, I would like to tell you that the neck of the womb has earlier also had abnormal changes, and then when the tissue sample was taken again this time, still
Mm-hmm.
it is having abnormal changes, and these abnormal changes now the report says that I'm so sorry that I'm saying this to you, and I got to be the bearer of this news that it is a cancer of the neck of the womb.
Oh, oh my God. What are you saying, doctor? Cancer? But I'm just
Yes.
36. How is that possible?
I understand, Susan, your concerns, but yes, most of the cases are seen mostly in the later stages of later age, in the advanced age. But when certain high risk, if present, high risk factors are present, then the cancer may develop in the earlier age as well.
Doctor, but what are we going to do now? I mean, how are we going
Yeah.
to consider the treatment? I mean, will it affect my baby?
So now, as you are pregnant, we would not be doing any treatment now, or I would be involving the multidisciplinary team, the oncophysician, oncosurgeon, to make a decision about it. So, as this stage is not advanced one, it is stage 1A2. So the plan which we would be having is First, I would like to ask you, Susan, that after this pregnancy, are you planning to have pregnancies in the future as well?
I'm not given that a thought as yet.
All right. Okay. So in case this stage, at this stage, the management depends on whether the individual, the female wants fertility of.
Yeah, time's up.
Okay.
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 Yeah, so what was the plan?
The plan is if she wants pregnancy in the future again, then we can go with the conization and lymphadenectomy as the lymph node, this invasion is there in the stage 1A2, or trachelectomy with lymphadenectomy. And if she is not willing, then we can go for simple hysterectomy
Okay.
after the pregnancy.
All right. Okay.
And
Fine.
I'm not recalling much, but there is a plan during cesarean section also. I'm not sure whether we have to say this or not,
Right.
performing the
Yes.
procedure.
Yes. Yes. That's right. You did well actually, but you did not get time to complete the station.
Mm.
If you had time, you would have finished. Your history taking bit was good, but what happened was in the middle when that colposcopy, you went on and on about the same thing. Like I asked you,
Mm-hmm.
was there any problem during colposcopy? You just say that there is colposcopy is such
Yeah.
a safe, but during biopsy there may be heavy bleeding because of the pregnancy. That is all.
Mm.
Okay.
Mm.
And then
Okay.
once once you see that, I would give you the report, and then the rest of the station would be about squamous cell carcinoma in pregnancy. Now, one more important thing which we were discussing the other day, if you remember, punch biopsy of squamous cell carcinoma invasion up to 4 millimeters. Can you stage the disease
Ah, yes.
with
No,
this?
no, no, no. Yes, not in
Correct.
bench biopsy. Yes.
Yeah, yeah.
Okay.
So, basically, as we have discussed earlier, so with just punch biopsy, you're getting just one part of the cervix. You are not
Mm.
getting the entire circumference of the
Okay.
cervix, which is
We
why
would be
you cannot
doing
stage the. Yes, you will do a cone.
okay.
Basically, you will
Cone
do a
again.
LEDS
Okay.
procedure. LEDS cone.
Mm.
Cone is anything. Whether you do it with a LEDS, that is electrical loop, or whether you do it with laser, or whether you do it with cold knife. All these are called cones. Okay, LEDS procedure
Okay.
is also
Okay.
cone. Remember that.
Okay.
Okay, but
Okay.
LEDS procedure uses an electrical loop. So what can happen is that the edges can get burnt, and sometimes the
Hmm.
margins are not clearly seen on histopathology. So
Hmm.
you can do a cone biopsy with a laser or with a cold knife as well, or with a knife basically. Okay, but again there may be risk of bleeding in pregnancy, so you can just say let's. Okay, basically
Hmm.
with punch biopsy, this is for everybody else also. I know Apurva, you know about this, but remember that when there is a microscopic lesion and punch
Hmm.
biopsy is taken from the cervix. Okay, punch biopsy
Hmm.
first of all is taken because there is no major macroscopic lesion on the cervix. Only when you have colposcopically identified abnormality on the cervix, you
Hmm.
would take a small biopsy from the cervix. Correct?
Okay.
And that biopsy may not be representative of the entire cervix. So if that
Hmm.
particular biopsy has 4 millimeter invasion, there is a possibility that the other cervix may
Hmm.
have an invasion
Hmm.
more than that. Then the staging
Hmm.
would change, which is why when you have a
Yeah.
microscopic lesion, you would do a conization or a LEDS
Okay.
procedure
Let's.
to
Okay.
take the entire specimen out, which is representative of the entire cervix.
Okay.
Okay, so the next step here is to do a LEDS procedure so as to know if there is any other area in the cervix which has invasion more than this particular invasion, which is given here. Not just that, you also need an MRI to check if there are lymph
Hmm.
nodes, right?
Hmm.
Because if there are obvious lymph nodes and then you do a sampling of the lymph node and it comes positive, it will be stage 3 directly. So you basically
Okay.
what I'm trying to tell you is you cannot stage the disease just based on a punch biopsy report. You need for a microscopic lesion. For a macroscopic, obviously there is a big lesion. So you just take the lesion biopsy and prove that it is cancer and then measure the lesion because it's a big lesion on
Hmm.
MRI or clinically, and then you know it is basically whatever stage 1B or 2A or whatever. But If it is a microscopic lesion, you don't know the extent of the microscopic lesion. So you have to look at the entire cervix to know if there is any other lesion existing. And you have to do an MRI scan to know if there are lymph nodes or invasion or anything of that sort. Okay, so
Hmm.
only then can you stage the disease. So first is the information gathering. You did well. You asked her for her background information, which was very good. It is always important to assess what the patient already knows, right? So ask her, yeah, currently she's 16 weeks. So what are the booking investigations, screening, whether this was a planned pregnancy, what contraceptives, all these things you did very well. Current complaints also you asked quite well. Screening, what was done, why was the LEDS procedure done, was what was told to her to follow up, etc. But remember, if it is CIN2 or 3 or CGIN, the follow up, even if it's a pregnancy, you have to do the follow up. Otherwise, you delay. If it's a routine screening that is scheduled and she's pregnant, then the routine screening can be done after the pregnancy. But if it is
Okay.
follow up after CGIN or CIN2 and CIN3, it is done in the
Hmm.
pregnancy. That is why she was screened in pregnancy. So
Okay.
that has come as positive for HPV. And what is the thing? If HPV is positive after treatment for previously treated, she's for CIN3. So she's already treated for CIN3 and now she's HPV positive. So you would do a
Hmm.
colposcopy irrespective of what the cytology says actually. Okay, so she would be
Acha,
for
okay.
colposcopy straight away. Yeah.
Okay.
So, but the cytology is just given as a clue to you because it is showing HSIL. Okay.
Hmm.
So then you would do a colposcopy in this case. So that is what you need to recommend. So you have to ask other history, like as you did sexual history, previous partners, STI screening, and that was excellent. Okay, what are the future fertility plans, which you asked later, but good. Medical diseases, surgeries, allergies, addictions, BMI, support, mental health, examination. When you say most important other than per abdomen is you want to look
Hmm.
at per speculum
Hmm.
examination because
Hmm.
to know if there is any
Any
gross
obvious
abnormality
reason.
on the
Hmm.
cervix, which you can
Yeah.
just take a
Okay.
bigger biopsy of. Okay. And TBS is important here for cervical length because she has history of LETs. That is why.
Oh,
Then
yes. Yes. Okay.
yeah, so that is just one thing that you need to mention because the rest of the station again is all about doing the LEDs
Hmm.
again and all that. Then yeah, so would basically need HPV screening. I've just written it here because it's important for you to understand that because she was CIN3, now she needs HPV screening, which is already done and provided to you. So colposcopy, you say that is safe, but biopsy, if we need to take, then it may result in bleeding and infection in pregnancy and can there is a risk of abortion. Okay.
Hmm.
Your communication was fine, BBN was fine. Effects of once you know that there is cancer in pregnancy, what are the she's worried about? What are the effects of the cancer? She asked it is it going to affect my baby? So you need to
Hmm.
say that the cancer may not affect the baby, but
Hmm.
there may be effects on the baby because of the treatment, which I would be
Hmm.
subsequently discussing. Okay.
Hmm.
Then there is a
Okay.
risk of abortion, preterm labor, and growth problems for the baby. And as far as the effects of pregnancy on the cancer is, there is no much data you can say, but it's mentioned in the TOG article that certain studies have shown poor prognosis, but you can just mention that there is no much data on this. So basically, what you're going to tell her is that you're going to explain to her about the initially the risk of biopsy. You've already told bleeding, infection, preterm labor. Now that she's established diagnosis of cancer, she would need a team of doctors, and I've specified the team that would be required. You need not say it to her. Say to her, cancer specialist at a cancer center. Okay, but if it's a again structured discussion, you will need to know each of these people in the team.
Okay.
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 So
Okay.
MDT. Then since it was a punch biopsy, it cannot establish the staging, so you would need to take a let's would be needed, MRI would be needed. That would complete your staging. Now,
Hmm.
if the MRI is not showing any abnormality and let's shows the same thing, the stage would be 1A2. Okay, in this case. Okay. So you just say, make a mention that we would need to do an MRI and we would need to do let's procedure, the procedure that was done the last time, to make sure that the cancer is not invading the tissue any further. That is what you need to say. And um, then go to the management. Okay, so management, since she is less than 22 weeks, okay, the talk divides the management into less than 22 weeks and more than 22. Since she is less than 22 weeks, what you would do is you would do a staging lymph node dissection first. Okay, because if you
Okay.
find an obvious lymph node, the stage you know is stage 3, and the stage 3
Hmm.
treatment would be chemoradiation. Okay,
Hmm. Hmm.
so in
Hmm.
that case, you would advise her a termination of pregnancy, but she may not be
Okay.
wanting a termination of pregnancy. So how do you say it? You
Hmm.
say that since this is cancer, the one of the first steps that we would take is we could offer you a keyhole surgery to check the lymph nodes. Okay, so
Okay.
if lymph nodes or the lymph glands, you can say in lay language. So if the lymph
Hmm.
glands show evidence of cancer, then the treatment would include a radiation therapy and chemotherapy, which may be harmful to the baby, which is why we usually, I'm sorry to say this, but which is why we usually advise termination of pregnancy. Okay, or you can say
Hmm.
this later. First say what happens if the lymph node is negative. So you say if the lymph nodes are staged and the lymph nodes are negative, then you can be offered, then there are choices that you can be offered. You can choose to continue the pregnancy as such, and
Hmm.
we could offer you chemotherapy. Chemotherapy only beyond 14 weeks is safe. Not first trimester is teratogenic. Beyond 14 weeks is safe. Only chemotherapy.
Hmm.
So you say we can offer you chemotherapy till the baby becomes mature. Once the baby is mature, we can do a surgery, that is cesarean. At the same time, we can treat you for the cancer by doing a surgery for cancer. Okay, that is what you were saying.
Okay.
And if she doesn't want to take that risk, then there is a choice of having a procedure called trachelectomy, wherein only the cervix would be removed. But what
Hmm.
the British Gynecological Cancer Society says is that it should be discouraged in pregnancy because of increased blood loss and poor perinatal outcome. Okay, so what you need to tell her that trachelectomy is a procedure that can be considered. However, it usually results in preterm labor and increased blood loss. So the current guidelines discourage this particular procedure in pregnancy. Understood?
Okay.
So, and
Hmm.
if you're saying trachelectomy, you have to say that a cervical stitch would be put through the tummy. Okay?
Hmm.
And then they also say in the talk that if trachelectomy is done, then you have to offer fortnightly urine and genital screening because of risk of infections. But again,
Hmm.
you have to complete a lot of points. So this is not a very
Hmm.
important point. You need not say. What is more
Hmm.
important is once the baby reaches maturity or baby is more than 24 weeks, we could offer you steroids because in case delivery is required, baby would cope better. Psychological support counseling is very important in this station. Okay, so you say
Hmm.
that going through all this, I know could be stressful. So we do have support and counselors to help you. All right, that is how you
Okay.
say it. As far as delivery is concerned, the mode of delivery is not going to, this is just additional information because in this station you're going to talk about cesarean only, but
Hmm.
you can consider a vaginal delivery. But the thing is, in vaginal delivery, bleeding can happen because of the mass that can bleed, and episiotomy site metastasis is more common than abdominal wound metastasis. So that is why usually cesarean section is offered. Traditionally, classical cesarean section was done, but unless the tumor is large and encroaching on the LUS, you can still offer a LSCS. Okay, and the appropriate gestation for delivery, if neoadjuvant chemotherapy is given, is around 34 to 36 weeks. Okay, so you
Hmm.
don't wait too long. You wait till around 34 weeks, you can say. You give steroids and deliver the patient. Okay, breastfeeding is contraindicated during chemotherapy. That is what you need to remember.
Hmm.
And it's mentioned in the talk that advice from a pharmacist should be sought prior to the decision to breastfeed. and with a minimum period of 14 days from the last chemotherapy session before breastfeeding. This is just put here. You don't have to say this to the patient, but again, in a structured discussion, maybe you may have to say all those points which are more of theoretical. Okay. Then just to recap, stage-wise treatment of cancer of cervix in pregnancy. If it is stage 1A1 without lymphovascular space invasion. Lymphovascular space invasion is the invasion of cancer in the tissue and not the lymph vessels and the blood vessels. Okay, it is the blood spaces and the lymph spaces in the tissue. So when you're taking a cone specimen, in that cone specimen, lymph vessels are involved or not is what is checked. So if there is stage 1A1 less than 3 millimeters without lymphovascular space invasion, conization would suffice provided margins are negative. Okay, that means the cancer is not reaching the margins. If margins are positive, you have to take another cone or another LEDs to check how deep it is. Stage 1A1 with LVSI, 1A2 and 1B1 is what we just discussed. Okay, these are small cancers, but here 1A1 with LVSI. So the difference arises only because in these stages, or when there is LVSI, 1A2, 1B1, the risk of lymph node involvement is higher. So in these cases, what you have to do, the first thing is staging lymph node dissection. So if lymph node is positive, you terminate because it's the radiotherapy that you would need to give her. Or if she wishes to continue, give her neoadjuvant chemotherapy and then either do a cesarean and at the same time you can do a radical hysterectomy, or you can just give her chemoradiation if lymph nodes are positive. Okay, so this is the same thing that we just discussed. This is the same stage. If it is 1B2, okay, so in 1B2 is where it is 2 to 4, it's a gross lesion, 2 to 4 centimeter in size, right? Limited to the cervix. So if that is the case, you can consider, yeah, radical LETS procedure or a trachelectomy may not be effective because they are bulky tumors. Less than 2 centimeter, you can consider trachelectomy. Here you cannot consider a trachelectomy because it is between 2 to 4 centimeter. So the same principle applies. If she is not willing for a termination, you put her on neoadjuvant chemotherapy and then do a cesarean section with a radical hysterectomy. Okay, here it is 2 to 4, so you can do a radical hysterectomy. No trachelectomy, no LETS procedure would suffice for her. Okay, why this distinction between 22 weeks and more than 22 weeks is because less than 22 weeks you can first actually do a lymph node sampling. Okay, so to find out whether it is stage 3. More than 22 weeks, because it is lymph node sampling, if you are doing first, it is done laparoscopically. So if it is more than 22, you will not be able to do laparoscopically. That is the reason why the distinction of more than 22 and less than 22 is here, given here. Okay. So if in this case it is more than 22, you might as well wait with neoadjuvant chemotherapy for fetal maturity and then do a cesarean section. Okay. So again, you just have to remember the principles that if the cancer is tiny without LVSI, 1A1 without LVSI, cone is enough. If the cancer is tiny with LVSI, that is microscopic with LVSI, or a small tumor, 1B1, you can consider trachelectomy, you can consider radical hysterectomy. Trachelectomy is not preferred in pregnancy. Okay, although the TOG mentions, it's mentioned that the guidelines say that it is to be discouraged. And you can, same thing, either a termination of pregnancy. If she wants to continue, you put her on neoadjuvant chemotherapy till such a time that the baby is mature, and then you do a cesarean section followed by treatment. The treatment will depend on how big the tumor is. If it's a very big tumor, the treatment would be chemoradiation. If it's a small tumor, can be amenable to radical, then the treatment would be radical at the same time that you're doing the procedure, cesarean. Okay, so that is roughly that you need to remember for these things. Okay, 1B3 and above, what you're going to do is they are bulky tumors, and beyond that, it's basically 2A is basically a stage where it is gone beyond the cervix. So in such cases, you put her on neoadjuvant chemotherapy, and once the baby is mature, you consider a cesarean section for her, and either the surgery, depending on what the stage it is, either a surgery or chemoradiation. Okay, depending on other findings like whether it is invading, whether it is whether the lymph nodes are involved, etc. Okay, so this is the gist of it. Okay, so just remember for the exam sake, if it's a SPT particularly, you don't have to remember details. You just remember first thing, you can tell her that if it is 1A1 without LVSI, you can tell her that cone would be sufficient. She can deliver and whatever, you can have a baby. But if it is anything more than that, you tell her that if the lymph nodes are positive, it's better to terminate because the treatment is chemoradiation. If not, she can continue, and till at least the baby is mature, you deliver by cesarean section, and depending on the actual stage, it's either chemoradiation or surgical uh, radical hysterectomy. Okay, so that is the in brief how to remember for the exam. Okay, so this a little more about chemotherapy. Again, maybe important for structured discussion, not so much for SPT. You need to know that it is not recommended in the first trimester. It has a 10 to 20% risk of malformations. After 14 weeks, it is relatively safe. And timing of cesarean is important with respect to the last dose of chemotherapy. Because of neutropenia that can result after chemotherapy, it is better to have a gap of 3 weeks after the last dose of chemotherapy. That is why it is not recommended that you give chemotherapy after 35 weeks because there is a chance that she may go in labor. Okay, so this is what you need to remember about chemotherapy in case it is asked specifically in a structured discussion. Then this is another thing that you need to remember because the station was long, this was not included as an agenda. So this may come as an agenda where she wants to preserve her fertility. So what you need to remember in CS cervix, in early stage CS cervix, you can preserve the ovaries provided it is squamous cell carcinoma. If it is adenocarcinoma, you need to remove the ovaries because there is a 4% chance of metastasis to the ovaries with adenocarcinoma. And another thing that you need to remember, if you're considering radiotherapy and she's willing to preserve the fertility, then you need to tell her that radiation therapy can affect the uterus as well as ovaries. You can do something about the ovaries, that you can transpose them higher up in the abdomen away from the radiotherapy field. Okay, and you will not have a problem, so much of a problem of ovarian failure, although you can still have some scatter radiation or because of the chemotherapy problems of ovarian failure, but it would be a lesser extent. The uterus, if it is damaged because of radiotherapy, then it may again she may not be able to conceive, she may need a surrogate, but you can preserve the ovaries to a certain extent. Okay, so that is about fertility preservation because this can come as a station. It's in itself. All right. So that this is another thing. Yeah. Okay. So any doubts? Any questions?
Ma'am, after 22 weeks, how are we assessing the lymph nodes?
No, then you cannot assess the lymph nodes. If she's gone beyond 22 weeks, you just wait for her to reach, say, 30 weeks, 32 weeks, or even further, if you can wait, and then decide on the delivery. And in the meantime, whenever you're adopting the approach of waiting, in the meantime, you give her neoadjuvant chemotherapy. Okay, because there's nothing else that you can do,
Hmm.
right?
Dr. Ankita, this neoadjuvant chemotherapy says cisplatin is preferred in pregnancy or there is a change
No,
among it?
carboplatin and paclitaxel is the preferred because cisplatin has nephrotoxicity, even in other patients. Carboplatin, paclitaxel.
Ma'am, in this scenario, will we be given the stage of the cancer? We only given punch biopsy. Will be given other information as well?
as in this case, you may have to know the stage of the cancer. So that it may be just given to you. And as I said, if punch biopsy, you cannot stage the cancer. Okay, you need to take a LETS specimen and you need the MRI, because now the diagnosis or the staging of cancer cervix is not just clinical, it is radiological as well. So for staging cancer cervix, you need MRI, as well as if it's a microscopic lesion, you need a LETS procedure. Okay, if it is a macroscopic, then punch biopsy from the macroscopic would suffice, because it's a big lesion. You know, you can measure the dimensions of the lesion, hence. But if it's a small microscopic, you cannot measure the dimensions accurately until and unless you have sampled the entire cervix, which is why you need a LETS specimen. All right?
Okay. Thanks. Yeah.
Yeah. Any other doubts? Okay, so if there are no further doubts, I think we can wind up. If there are any further doubts, you can always post on the group, all right? So we would be happy to answer, all right? And what's important for you to understand for part three, for those of you who have recently done your part two and are attempting part three for the first time, uh, most important is that you need to cover points in the respective domains. Okay, like as we just discussed today. Okay, don't elaborate on one particular thing and just go on talking about one particular thing. You need to say the points. Most important points are like those in this the situation of abuse. So all the social factors you have to enumerate one after the other. That is more important than just talking about one aspect of management. Okay. So points like PIL, support, MDT, counselors, all these things are very, very important. If you realize that you're running out of time, just make a mention of these points, because it's important to get your points ticked in the examiner's answer key. Examiner sits with an answer key. You understand that? So basically, under each domain, there are certain points which are mentioned, just like how I showed you the points under the domain. So there are points mentioned, and as you are doing the station, the examiner is marking, okay, this is done, this is done, this is said, this is said, this is said. So it's important that you cover points in the domains. All right?
Dr.
Okay?
Ankita, in my recall
Yeah.
last time, this
Hmm.
year cervix, she had 2 times LEDs, and then she came with MRI report showing this lesion 4 centimeter and above, and this parametrial involvement. This MRI report
All
was
right.
given.
Hmm.
So in that case, this chemoradiation is the only treatment. Yes.
Correct. Yes. In that case, because it's a bulky lesion with parametrial involvement, if she asks for surgery, you say that there is very high morbidity. The surgery would be difficult, almost impossible to do, because it involves usually the ureters and other important organs. So it may not be possible to do the surgery. And even if she requires the surgery, I mean, even if she goes for the surgery with that much of spread, for treatment, she would require radiation after surgery, and combined treatment with surgery and radiation would increase her morbidity, or would result in a poorer quality of life. Okay, so you can tell her that, and which is why it is better to primarily consider radiation therapy in such a case. Okay,
Okay, thank you.
yeah, all right. Good night, everyone.